Well, hello again and welcome back. We've had great discussions this morning, and our next discussion is on climate and health, and specifically climate and infection control. Our moderator is Frank Sesno, Director of Strategic Initiatives at the George Washington University School of Media and Public Affairs. And on the panel with him are Dr. John Balbus, who's the Acting Director for the Office of Climate Change and Health Equity at the U.S. Department of Health and Human Services, Diane Flayhart, who's the Director of Global Public Health and Antimicrobial Resistance Initiatives at Becton Dickinson, Dr. Robin Patel, who's Director of the Infectious Disease Research Laboratory at Mayo Clinic and representing the American Society for Microbiology, and Mark Young-Ruo, a Daoist monk, author, and educator. You can find everybody's bio in the link in the chat. And so, Frank, with that, I turn it over to you.
Well, Mike, thank you very much. It's delightful to be here. It's an honor to be here, and I really look forward to the conversation, important conversation we're going to have today. As you say, the discussion that we're going to have here is on climate change and its impact on infection control. There have been recent studies that find that increases in atmospheric temperatures, and we certainly have experienced those around the world this summer, are contributing to the rising prevalence of common pathogens in the United States, including antibiotic-resistant, antifungal resistant strains. According to the Centers for Disease Control and Prevention, antimicrobial resistance is an urgent global public health threat and has claimed the lives of at least 1.27 million people worldwide, contributing to another 3.5 million deaths in 2019. In the United States, more than 2.8 million antimicrobial resistant infections occur each year, it's estimated. Further, resistant hospital onset infections and deaths both increased at least 15% during the first year of the pandemic. In a 2021 analysis, the CDC also reported that after years of steady reductions in healthcare-associated infections, U.S. hospitals saw significantly higher rates of 4 out of 6 types of those infections in 2020, many of them resistant to antibiotics or antifungals. So there's a lot to discuss here, both on the medical side and on the climate side, and of course, where they collide. Before we take that deeper dive into how increasing climate temperatures impact infection control, I'd kind of like to start with each of you for the conversation at sort of the 20, maybe the 30,000 foot level, and ask you all in a minute or less what you think policymakers and the public least appreciate or understand about climate and infection control. And John, let me start with you.
Sure. So 30 seconds. Policymakers do not get that climate change is not only affecting health now, but healthcare delivery right now. They think it's an environmental issue. They think it's about fossil fuels and energy and not about health sector. And the absence of the understanding of the impacts on the health sector is the thing we're trying to change.
Diane?
Yeah, no, I think one of the challenges is really understanding, we talk about the link of how the environment impacts living creatures like humans and animals. What we don't talk about is how that environment is impacting the smallest of those creatures, the bacteria, virus, and yeast. And they're being just as impacted as the larger creatures here on the world. And I think some examples, when you start to think about climate change and microorganisms, it's like azole-resistant aspergillus. It's been around. We know it exists. It's become resistant due to overuse of antifungals in the environment, the agriculture and flower industries. Yet many hospitals in Europe don't have air conditioning, but they keep their windows closed because it hasn't been too hot. But as we've seen in the news over the past summer, these heat waves have caused them to open their windows in the hospitals, and these resistant spores are coming into the hospitals and infecting patients. So the direct link from from opening windows and how bugs can come in.
Wow. Robin Patel, from your perspective?
I'm going to comment on this from the perspective of a microbiologist and an infectious diseases physician. Antimicrobial resistance is really threatening the way that we live healthy lives. Because it can affect people who are otherwise healthy or who maybe have another type of medical disease, a cancer, a transplant, an immunologic disorder. And in the past, we've just really trusted that we would have a drug to treat any infection that they might acquire in terms of bacterial infections or fungal infections. But today, because of antimicrobial resistance and ongoing changes in that area, we sometimes end up with patients who are getting treated with drugs that won't work, and they can have bad outcomes, not do well, even pass away as a result of this. So I really see this as an issue in fundamentally human health at the end of the day.
And you think that this is something that, as I baked into the question, that the public and policymakers don't properly fully appreciate at all?
I'm going to say this. I don't think any of us fully understand what's going on, but we know there's a problem. And we know that we need to devote more attention to this. ASM earlier this year published a paper that helps engage policymakers in what they can do to address AMR, and there are 8 specific recommendations. I'm not going to go over them here today, but this is a very complex issue that's only going to get worse over time. And we citizens of this world really need to figure out what to do about this, or it's going to compromise the health, our own health, the health of our loved ones, the health of the people that politicians serve in their communities.
Monk, I'm going to go over to you now for what you think people don't understand. And I should say that you actually are sort of a case study, unfortunately, in some of this, and we'll talk more about that later. But from the perspective of, excuse me, what people don't properly understand about this, your thoughts?
You know, my role is not a research scientist, it's a monk. And I look at the philosophical, religious, psychological underpinnings, historical underpinnings of the way we view the world, the way we view the planet, the way we view each other. So as I watch things unfolding on a variety of levels these days, from climate change to political issues, what I see is the need for a fundamental realignment, almost like an evolutionary leap, as Stephen Jay Gould, the Harvard professor, used to talk about saltatory sudden leaps in evolution, like when we got a thumb or when we stood up. Somehow I feel like we need a fundamental change in the way we consider what is the earth, who are we, what is our role, and understand the interconnectedness of things in a way that shifts our behavior, whether it's from human-centric to individual-centric, consumerism, paying no attention to things that we know are not good. And the work starts with each one of us. And that's my realm, my purview. We are a stone, we drop into the pond, the ripples go, and we cannot control where they go nor what they do. So we have to be pretty careful about the stone.
Yeah, let's go into that pond where the ripples are taking place now and consider what's going on. John, let me start with you on this. You're a physician and a public health professional with decades of experience working on health and health implications of climate change. So starting there, what have you seen in terms of how climate has affected our health over your career?
Yeah, so I'm happy to be here speaking to a microbiological and infection disease audience, because one of the first meetings I went to on climate change and health was around 1997, when we were examining the impacts of a really bad El Nino that was happening then, and trying to assess as epidemiologists whether there were small changes in infectious diseases. And we were looking at El Nino as a proxy of climate change because it wasn't quite as apparent then. And you couldn't really study the impacts of climate change, so we were using El Nino. And to be sure, we were not in the newspaper headlines 25 years ago. 25 years later, you just have to open up a smartphone or a browser, or this past summer, literally walk out the door, and we're in a different world. We're in a world where we're seeing very, highly attributable events scientifically to climate change, whether that's the devastating wildfires in Quebec and Canada, the heat dome that was unprecedented that beset most of the country this year, the rapidly strengthening hurricanes, which are highly attributable to climate change. So we've gone from a world where when we started, we were really thinking a lot about infectious diseases and what was going to happen with the infectious diseases. Now we're seeing this, working through in a context of disasters, and this is affecting people with NCDs, the heat stress and the heat mortality in the country, the infectious diseases, all of them have infectious disease carry-on effects, but there are many, many different things that are happening. Speaking of mold, when we have devastating flooding, as we've had throughout this country, in Vermont and in Western Massachusetts recently, and in Kentucky last summer, that sets up people for mold allergy and other kinds of mold infections as well. Most importantly, we're also seeing really devastating mental health impacts. This was something that was not as much on the radar screen 25 years ago. I remember I was testifying in Congress 15, 20 years ago, and it was after the second national climate assessment came out, and it said that climate change could have mental health impacts, and we were mocked. We were mocked on certain news channels because they said, climate change is making us all crazy. Now, anybody who's a parent knows that their child is being affected in really tragic and sad ways. And we're seeing headlines about diseases like vibriosis, diseases like, or not even disease, death from Naegleria fowleri, which is a parasite that enters into the brain in people swimming or water skiing accidents, that kind of thing. All of these things are moving to higher latitudes northward in the northern hemisphere. So things are observable now, and all these things that we were concerned about, and trying to get a handle on, we're actually able to observe and study, and that's a very troubling and disturbing reality for folks who have been working on this. So we've gone from a really small, underfunded little band of scientists seeing a problem headed our way to where we are now, which is a slightly less small, still woefully underfunded bunch of scientists and increasingly health professionals and health administrators now being called on to address this crisis because we're seeing it.
Yeah, and John, I can attest that both the mental health and the physical health issues among young people here, I hear it from university students all the time. It's real and it's personal, whether they're worrying about the future of the planet and whether they should have children or their own asthma and how it may affect them in that way. And we'll come back and talk about some of those things. Robin, I want to come over to you to ask you about some of the examples that you've seen, how we're experiencing these effects and consequences, but also to ask you why. You're a doctor, obviously, but why should the average person be tuning into this and caring about this in the way that this conversation suggests they should?
Right. Well, John mentioned many infectious diseases, some of which probably most people haven't heard about. I think people trust the healthcare system to figure out what's wrong with them, to make a diagnosis, and to get on the proper treatment. But many of the examples that John gave, and there are others as well, are infectious diseases that have been considered relatively rare or geographically restricted and are now moving to areas that maybe they didn't exist in before. So medical doctors that may never have seen some of these conditions may now be seeing them. If we think about an organism like cocci, which I think we're going to talk about later, a lot of us medical doctors were trained that there are certain regions in the country where that happens, but if you're not there and your patient has never been there, you're not ever going to think about it. But some of these infectious diseases can be devastating. I mean, Naegleria fowleri was mentioned. That organism has a very high case fatality rate. And, so physicians that aren't used to seeing that may miss it. And what does that mean for a patient that acquires one of these infections? Well, that's not good news.
And what are you most concerned about when you think about these different diseases? You rattled off a few and some of the concerns about the regional specificity of these. What are you most concerned about?
I'm most concerned about being able to make a proper diagnosis to get patients on the proper therapy. One of the things that we know about antimicrobial resistance is that we in the healthcare profession have used a lot of antibiotics empirically in human health, but we also know that antibiotics are used outside of human health and they're impacting what's happening. So for me, I'm really into diagnostics and making the correct diagnosis, but really that's a means to the end and not the end itself. The end is getting patients on the proper therapy. And we also need those therapeutics. We oftentimes today don't have drugs to treat some of the drug-resistant infections that we are seeing. And so we need efforts to develop new antibiotics, but also new strategies to make sure patients get the right antibiotics.
So Diane, let me come over to you on this issue of diagnostics in this space, because that's something you think a lot about and work a lot around. We're talking about vector-borne illnesses here, bacterial and fungal illnesses. So how do the precise diagnostics happen and help?
Sure. Yeah. As Robin was mentioning, right, rapid and precise diagnostics are critical to provide very important data to the clinician who's managing and treating that patient, as well as to inform surveillance. So one of the gaps is we don't understand where these organisms are and how they're moving around the world. And we know they move quickly. So by doing diagnostics and understanding what's causing a patient's infection, first, you can get their treatment tailored and focused. And then secondly, that data can be captured in a surveillance system. So we have a better understanding globally of where these organisms are moving and tracking. And a diagnostic does two things. One is it's going to identify the organism causing that disease. And that's going to give a path forward for that patient, for that doctor, for that patient treatment. And unfortunately, I have a very sad story. Just last week, we lost a dear friend to West Nile virus. Oh. And you would think that that would be one that we should be able to diagnose. However, he went to a small hospital locally. They didn't have that diagnostic available in-house. So by the time they did the spinal tap and sent the testing out, if the timeline was too long and we lost them. So that's a perfect example when we're talking about diagnostics and climate change. Now that was directly linked to mosquitoes in Canada by his cabin. No one thought when he said I was in Canada at a cabin, they didn't think West Nile. So if those diagnostics really help the clinician quickly understand so they can get that patient on the best treatment possible. And then when you start to think about bacterial and fungal infections, rapid diagnostics are also critical there because of that susceptibility testing. So that susceptibility testing will tell us what antibiotic or what antifungal will be most effective for treating that organism that's causing that infection. And unfortunately, today with antimicrobial resistance, it's not as easy as it used to be. Because before, there are a lot of choices of antibiotics a clinician could choose, and probably that antibiotic would work. Yet today, as we mentioned in the opening, the rates of resistance to antibiotics is very high. So it's critical that we get that right drug to the right patient at the right time to manage that infection. So diagnostics are the underpinning of all that. Those diagnostics are giving all those results that are allowing people to make those decisions. So improved use of diagnostic testing, both here in the US as well as globally. We won't even get into global South and the lack of diagnostics there, but really it's critical that we improve the use of diagnostics around the world.
Well, Diane, first of all, let me say on behalf of all of us here, express our condolences for the loss of your friend. That's just a terrible and sad, very sad story. It does point to the challenge here, though, because we're talking about a changed environment, literally, that includes the medical profession and clinicians who have to recognize or diagnose something that they've never perhaps seen before. And so what is needed to make sure that people in Canada have the information that they need to even recognize something that is not supposed to be there, but is now happening as you lay out because of climate change, or as partly as a result of climate change?
It really goes back to the access to diagnostics and the access to data to understand prevalence, burden of disease locally and globally. And that will inform not just the clinical care, but then, as we mentioned, the policies, right? To get the new antifungals, the new anti-infectives, the new antibiotics to market more quickly. That will happen once we have that data to inform our policymakers how bad the burden of these infections are.
So let's talk about a fungal infection that's now in North America, for example. one that's top of mind for this discussion, and that's valley fever. So that's largely spread through dust storms that have worsened, scientists will tell us, due to rising global temperatures and heat and all of that. So over the past 20 years, we've seen valley fever become somewhat more widespread, more of a public health concern. Monk, you have been living with valley fever. You're a passionate advocate for research. First of all, would you describe what is valley fever and how are you doing?
Sure. So I'd never heard of it. I moved here from Florida. I was here about a year. And every morning, often quite early because of the heat, I would go out to a park and do my Daoist practices, Tai Chi and so on. And in doing so, I would shuffle around in the dirt, kicking up clouds of dust with my feet and so on, all the while completely ignorant of any danger in doing that. I don't know when exactly I got it or where I was in this area. But I did a checkup when I was in Florida for that, and they found some nodules in my lungs, and the first diagnosis was late stage lung cancer. They put me in a PET scan, a full body PET scan, looking for Mets, and they didn't find any. They did 10 through the wall. I repeat, 10 through the wall to chest wall biopsies and didn't find any cancer. I came home to Arizona. I spiked a very high fever, ended up in an ER here where valley fever was very much top of mind. It's a localized thing. At least it's not in Florida yet. And they made the diagnosis. They put me on a nasal drug, that class of drug that's usually used for these things. And I didn't tolerate the drug very well. So they kept changing the drug to find one that would be more agreeable. And eventually put me on a study medication, an experimental drug, which is not FDA approved. And I guess what can say about that drug is that the company that makes it has high hopes that it will be an antifungal of wide application. And I guess be a little better tolerated than some of the other sort of chemo-like treatments. And so I've been on that for a year and a half or so now. And I'm not going to tell you that it's a cakewalk of a drug, but it's better than succumbing to a fungus, which has now disseminated through my body and taken hold in my brain, which is the hardest place to get rid of it. But I did have it in other organs, and I did pass away from kidney failure and was revived in an ambulance, was in a coma. I've had, to quote one of my physicians, he said, "This patient has been closer and longer to the gates of hell than any I've ever seen." So without morbid description, pretty bad.
Wow. How are you feeling today? How are you feeling now?
Dr. John Galgiani, who takes care of me here and who's a giant in this field, laughs when I tell him how I'm feeling, because he says that most people grab his white coat and say, "Doctor, don't let me die." And I say that my 4-hour-a-day Tai Chi practice is down to 2 hours. I think that's probably an optimistic description. I sleep a lot, much of the day, a lot of fatigue, not so much pain, but a lot of fatigue and a fuzzy brain.
Robin, John, Diane, I'd like to open the conversation here. And Monk, thank you very much for coming and sharing your own personal experience. First, what do we learn from this case in valley fever? How much more prevalent is this, as an example, because of the climate change that we're discussing here? And what does this suggest in terms of the research and the work that we need to do going forward? So there's a lot there, and I'll ask you each to be brief and share some thoughts. And Robin, why don't you go first?
Yeah, I mean, I've seen several patients with this infection. My primary practice is in Minnesota, so we don't have this fungus in Minnesota, but people do travel, and it can be a horrible infection. It's interesting that you bring up the analogy to cancer, and I'm so sorry they mistook this for a cancer in the first place. but it's just as bad. Some of these drug-resistant infections, these fungal infections are just as bad as cancers. And, you know, you would think that once diagnosed, we would have a magic cure for some of these, but we don't. And that case was made as well. So we need ways for patients to get the right diagnosis quickly so they don't go through invasive procedures, like you mentioned, all those biopsies that were done that I'm sure were painful and caused a lot of anxiety as well. But then we also need better therapeutics for these diseases, and we need to recognize the impact that these have on people. It's not okay for people to be living like this. And, you know, Monk, I don't know how long it's been. You didn't mention that, but I presume it's been some time. And unfortunately, I think it will be some time that you know, continue to live with this fungus.
John, over to you.
Let me say a few quick words about research and data and surveillance, because I think these are the fundamental underpinnings of the response we're going to need to have. I'll start with research. And I saw something in the chat. We have huge knowledge gaps. We're now, there's been this huge research push on the microbiome, and people, you know, in a setting like this, we're talking about fungus cells or, you know, bacteria, viruses in the human body. But the microbiome surrounds us, and you know, the microbiome in the soil, the microbiome in water, the microbiome, you know, living on trees and plants around us is incredibly vital for our agriculture, for our ecosystem services. And there's a huge gap there, and understanding what are the impacts of climate change on, you know, the microbiome, the environmental microbiome, in addition to the human microbiome, just an enormous research gap that I just want to put out there. There are many others, but that's one that I think about. You know, this concept of physicians missing the diagnosis because they didn't realize that this could happen where they were, you know, points to a whole need for building a better surveillance system and better early warning systems. Our office has created a new product called the Climate and Health Outlook in the last year. We take all of the 30 and 90 day seasonal, subseasonal forecasts that the federal government puts out. So that's temperature, precipitation, wildfires, floods, the spring pollen season, the hurricanes, put it in one place for the health sector, translate it into health impacts, and you know, hopefully raises this awareness that you're in a hot, wet spring, you're going to be seeing earlier vector-borne diseases. You know, the ticks are going to come out earlier. We talk about this in the Outlook, and we are about to take this from being a PDF newsletter that comes out once a month to being an interactive county by county portal. This kind of information resource can be translated into clinical practice and into the way clinical practice has evolved, where so much gets prompted by flags in the electronic medical record. So we're also working with HRSA, the Health Resources Services Administration, to try to start piloting ways that we can flag both environmental conditions and vulnerable populations within the electronic health records of community health centers, so the clinicians are primed a little bit more. They're not going in blind. There's more and more information coming to them. Problem with that is they're already being overloaded by all kinds of things. And there's a lot of noise and chatter. And, you know, on the flip side, the predictions that we get 30-day, 90-day forecasts aren't always super accurate. As we know, the weather next day forecast isn't always accurate, 39 days less. But this is the way we're moving to build that kind of fundamental data surveillance and indicators.
Diane, let me just steer a question to you from what was John was just talking about, which is the availability of rapid diagnostic and screening platforms. I mean, because we're talking about new and developing infections here, right? So if a new infection pops up, how quickly can you roll out new technology and get it in the hands of all the people who need it back again, especially if they're in parts of the country where this is just so unfamiliar because it's not supposed to be there to begin with?
Right. So, you know, so I think getting those new tests to market, there's several phases. And the first phase is really doing that initial research and activating the public health labs, the university hospitals, and the researchers who have the capability to design and validate new assays for these new pathogens. And one of the critical parts of that is having open platforms, open molecular platforms, so these researchers can develop these new tests quickly. The other thing they need, other than the open platforms to design these new assays, are public databases that once a researcher identifies a new pathogen or organism, they can upload those sequences to be available to other researchers designing additional assays. I had a chance to be at the CDC last week for a meeting, and they highlighted NextStrain. And NextStrain is a public database that gets updated real time with all zoonotic pathogens and their sequence data. So real time is a researcher anywhere shares that data, then it becomes public knowledge. And that's critical because all those researchers in these labs, whether the public health or university or private, like a company like BD, we can all look at that and then help design these new assays quickly. And I would say the other big part is collaboration. We saw with COVID, tests came to market very quickly, and that's because everyone rolled up their sleeves and worked together. So government agencies, FDA, researchers, universities, manufacturers all got together and got validated assays to market quickly. So we know we can do it, and we're going to have to do it again. So let's all keep sharing our knowledge so we can quickly get these new diagnostics available.
Let me throw a jump ball out to everybody here, and I'll throw out the question and just jump in or wave your hand, and I'll come to all of you, whomever. Okay, you just mentioned COVID. Here's what we've seen with COVID. Despite massive amounts of public information, knowledge, and all the rest, we have tremendous polarization around this, whether it's vaccines or anything else. So with respect to these kinds of diseases that we're talking about, with the skepticism it can garner and the polarization that we live with, how do you focus on this to lessen the skepticism and the polarization? I mean, we don't have people agreeing on climate change, right? Never mind the diseases that it may cause or maybe accelerating. So who wants to start that? Robin, you want to start that one, or anybody else?
Yeah, I'm happy to jump in. Again, I'm going to go back to people and people who get sick from these infectious diseases, and I'm going to take monk as an example. Yes, there's a lot of controversy out there, and I don't want to get into this, but we've identified that there was a delay in diagnosis, and we've identified that there's no magic bullet therapeutic. He's on an experimental therapeutic. But imagine if it could have been prevented in the first place. Now, I would say as a medical doctor, short of telling Monk to stay in Florida and not move to Arizona, if he's going to be in Arizona, there's not really anything I'm going to be able to tell him as a medical doctor to say, if you do this, you will not get COXI, because it's so easy to get it. I don't know what it was that you were doing that led you to get it, as you mentioned, or when you got it, but just physically being there is putting you at risk, right? So I don't think there's a behavioral intervention that can be made, or something of that nature. But we do know that for many infectious diseases, vaccines have made a huge difference in public health. I know there's controversy about safety about some vaccines, but we have many very safe vaccines that have fundamentally changed the epidemiology of infectious diseases. And I bet if Monk would go back in time and I would say, hey, I have a vaccine that I think you should take since you're moving to Arizona that I know is safe and effective and will prevent you from getting this thing that you're going to go on and get in the future, that he might go for that. So I think that prevention is another strategy that we haven't discussed that needs to be focused on.
Monk, you have thoughts on this?
Yeah, I put in the chat a few minutes ago about this. Well, if I had known, if I had a crystal ball, I would have stayed in Florida, I suppose. But I also certainly would have been delighted to have a vaccine. And the vaccine that is in development now, in a late stage, I would say, is going to be used for dogs first. But I've gotten updates from it because the people who are taking care of me are involved in the development of that vaccine. And of course, I am not, forgive the term, an anti-vaxxer. So I would have been early aboard that. had I known about this disease, of course. So I think it's an excellent point.
Diane, what's at risk if we don't make infection control, antimicrobial, and antifungal resistance research and drug development? If we don't make that a priority?
Right. I mean, I think at the worst possible way, it's truly going to undermine modern medicine as we know today. So we all have, we all know someone who has had cancer, and we all know someone who's survived their cancer diagnosis. But we also know that we've lost folks that have had cancer. But many times they're not dying due to the cancer. We've made tremendous strides in cancer care and medications. But patients are getting infectious diseases. Their immune systems are compromised. They have a higher risk for getting infection. In fact, I'll be presenting data Thursday at the same meeting that Dr. Patel's at Robbins at, talking about this, that we see that cancer patients have a twofold increase in getting a drug-resistant infection. So we know they get more infections, but actually they're even at a higher risk for drug-resistant infections. So patients who have cancer are dying due to infectious diseases, not due to cancer. So I think when I say, how do we get people more engaged around this, is really having people understand this topic of infection control and infectious diseases impacts all of us at the most basic medicine that we are receiving as humans.
John, your thoughts?
Well, Frank, you were originally asking about politicization and polarization, and the analogy I gave of starting out when you looked at a newspaper 25 years ago and now you look on your cell phone, I think that's part and parcel of what is really, I won't say intractable, but a very grave problem that we have now, which is the sources of misinformation and disinformation that are fanning the fires of politicization and polarization. It used to be that health was not a polarizing topic, and Research America well knows that support for biomedical research at NIH was one of the most popular things among all political flavors of the United States. But with the COVID pandemic, we have seen a really, as a public health professional, kind of scary and devastating turning against basic tenets of public health. The idea that public health professionals are dedicated to the well-being of populations seems to be not turned on its head, and there are attacks on state medical officers and state health officers, and they're under a disinformation that they're actually out to harm people. So there's research going on now to try to understand, how do we walk back from this situation where we have just fragmented communication. We're not all listening to the same news. We're not reading the same newspapers. And the differences contribute to these really stark and dangerous, polarizations.
So you posed the question, John, how do we walk back from it? How do we counter this? Do you have an answer to that?
I don't have the answer, but I'm talking to folks who are I think I'm going to turn it around, Frank, because I think it's your discipline and your expertise, understanding the psychology of communication. And, I think that what we have is in moving our way of receiving information from a piece of paper or a man or woman speaking to us on a television at night to something we click and we get the dopamine buzz, it has completely changed the way that that information interacts with our neurobiology. And we're going to have to harness that, understand that, harness it, and use it to some kind of more collective good and anti-fragmentation if we're going to get through this. And it's daunting, but I think it's doable.
Let me, we've got to wrap up here, but before I do that, let me come back to the end where we started at the beginning with asking you each for about a 30-second response. As we consider this conversation, we've talked about what climate change is doing and how it's affecting these diseases, the diagnostics that are needed, the research that is needed. If you had an opportunity to have a conversation, as you do with professionals, and maybe the President of the United States is there thinking about what he funds, or the Congress is there and thinking about how you convince them, what is one thing that you think the community should be insisting on or really advocating for as we think about this growing problem going forward. And Monk, I'm going to start with you. And I'm going to, because of the time, just ask you to be as brief as you can.
In Arizona, the degree of communication about this disease is laughably falling short. And, you know, a lot of people are coming to Arizona. It's maybe the biggest influx anywhere. So I think that, you know, the state government would not like to have the reputation of being a state which is dangerous to move to or work in or live in because of a very serious disease. There's a lot of money, there's a lot of real estate, there's a lot of business that would not like to see that. So I think we have to be pretty frank and straight about what the I guess what what the priorities are for our communities, and keeping people safe may be more important than opening another shopping mall.
More and better information. Robin?
Yeah, I mentioned earlier on that the American Society for Microbiology put out 8 policy recommendations for how to address AMR, and I would direct policymakers to those recommendations. In particular, I'd like to highlight the first, which is supporting innovative research to understand the development and spread of antimicrobial resistance and how pathogens react to countermeasures.
Thanks. Diane?
Yeah, I mean, I think on an individual level, it's having people, we feel comfortable asking for antibiotics, but we need people to ask for tests. So, I would encourage every individual when they go see their doctor when they're not feeling well is what diagnostic tests are you going to do, and demand those first before you demand the antibiotics. And then from a policy perspective, if we're willing to fund billions of dollars of cancer control, the Moonshot program is a very well-funded program. Let's move some of those dollars to also creating new antibiotics, because we know antibiotics is a critical tool that our oncologists need.
John, you get the last word.
I'm going to go back to where I started, which is the neglect of the health sector and the solution space for climate change. So the health sector is one of the biggest polluters in this country. About 8.5% of all greenhouse gases from the United States are associated with health sector activity. It's by far one of the biggest economic forces, 25% of our GDP in most small towns, biggest employer. And yet the policymakers don't see the health sector as having an important role in either the solution space because of reducing that pollution. And of course, our office is working on decarbonizing the health sector, but also the protection space and the protection of populations and supporting the health sector through education, through research, through direct funding of health entities to engage in the protection of those communities. So that would be where I would end up with the communities calling for the health sector to come and be a part of their broader climate change resilience and adaptation solution space.
I want to thank you all, and I'm going to invite Mike Coburn to come back in and make some closing comments here. But I would say this, John, you asked me, I come from the media and I've done a lot of reporting on this and a lot of observing, and I teach in this space. And the one piece of advice that I would give to anyone who's participating in this conversation is reach out to the people in your communities who are the communicators to the public. That may be local news organizations, it may be libraries, it may be schools, but explain that you're there to talk about health. This has not got anything to do with ideology. If they care about their health and the health of their loved ones in the community, it's just have an informational conversation. They can do with that information what they need, but be a resource because you've got that information. And most news organizations and others actually do care about the health of their communities. And in most cases, we can make some progress there, but it takes constant work. It's not one and done. This is an ongoing effort, and there's a lot of learning that needs to be done. Thank you all very, very much. And it's, as I say, it's been an honor and a pleasure to talk with you and listen and learn from you. And Mike, over to you.
All right. Well, thanks, Frank, and everybody on the panel for joining us for this terrific conversation. We are now moving on to the next part of our program. If you go back to the lobby, you'll be able to join our session on combating misinformation, which is a big challenge for our sector. And this conversation will be led by our Senior Vice President for Strategy and Public Engagement, Jenny LeRae. So we'll look forward to seeing you in the next session. And again, thanks, panelists, for this important and terrific conversation.